lecture today about the postmenopausal bleeding. Postmenopausal bleeding is a vaginal bleeding that occurs after 12 months of amenorrhea in women who are not receiving replacement therapy. Causes: CA endometrium, most common cause, and is a prolonged estrogen stimulation of endometrium of unopposed by progesterone. The source may be either exogenous estrogen or peripheral aromatization of estrogen and or estrogen producing tumor. Tamoxifen also stimulate of endometrium to risk factor for CA endometrium. Differential diagnosis can originate from gastrointestinal, hemorrhoid, penile fissure, colorectal cancer, or lower reproductive tract cause atrophic vaginitis, vaginal fissure, tumor, vulval lesion, tumor, cervical lesion, or any tumor. Number 2, upper reproductive tract cause atrophic endometritis, endometrial polyp, endometrial hyperplasia, CA endometrium. Diagnosis: according to the clinical examination and ultrasound finding, first of all, GIT etiology rectal examination should be done, stool or occult blood, proctosigmoidoscope should be done. Lower reproductive tract exclude because of local if atrophic vaginitis or by PV examination and pelvic exam, pap smear for exclude CA cervix, and appropriate biopsy from the endometrium layer. Either by evacuation or evaluation of upper reproductive tract cause can be identified by the tissue diagnosis obtained by endometrial sampling. Endometrial biopsy, either by hysteroscope as outpatient and take endometrial biopsy, and if endometrial polyp also removed. Dilatation and curettage is a good standard evaluation in postmenopausal bleeding women. Hysteroscope done at time of diagnosis, dilatation and curettage for polyp and operation resection. If small endometrial polyp, small cervical polyp should be removed with the operation. Pap smear have a poor sensitivity for endometrial cancer. Only 40% of cases are be identified because we have take the sample from the lower part of the uterus, not from the body, just from the cervix. Risk assessment: benign condition is most frequent cause of postmenopausal bleeding, but endometrial cancer is the most serious potential underlying cause. So always we do DNC to exclude endometrial cause. Investigation all bleeding during menopause. The duration or amount staining versus growth of bleeding does not make any difference. Postmenopausal bleeding and HRT, hormone replacement therapy. The occurrence of uterine bleeding or spotting after the initiation of HRT is not unusual. More than half of HRT users will some spotting or bleeding at the beginning of the therapy. Usually such bleeding is lighter than the menstrual period and less with time after 6 months of HRT, and it stops completely in most women. Abnormality of the hematological system may lead to possible cause of postmenopausal bleeding, may be systematic condition. Rare condition: abnormal uterine bleeding will be the first sign of leukemia, blood dyskaryosis, overuse of anticoagulant medications such as aspirin, heparin, warfarin, and other drugs. And this may contribute to postmenopausal, and we stop hair drugs and we show if the blood after exclude local cause. So evaluation of endometrium by either ultrasound, transvaginal, non-invasive test, and it should be done for all women with postmenopausal bleeding. Diagnostic tool: either by vaginal ultrasonography or hysteroscopy or hydrosonography and endometrium biopsy, dilatation and curettage biopsy, or also office biopsy, hysteroscope, guided biopsy, and this last one used as therapeutic and diagnostic. Vaginal ultrasound done for all patients to exclude endometrial, to reveal endometrial thickness from the myometrium to the myometrium, and according to the age of the mother should be assessed if hyperplasia or not. This measurement of endometrial layer in patients with postmenopausal bleeding. Saline infusion sonography. This done by introduction of intrauterine fluid. Saline infusion sonography during transvaginal ultrasound is one of the most significant advances in ultrasonography of the past decade. Transvaginal ultrasonography, the finding of the thickening central endometrial complex with or without cystic lesion, changes and non-specific. هذا بالالتراساوند ترانسفاجينال العادي اللي بدون بنستعمل السلاين normal saline ندفعه وياه بالكاثيتر. After pushing the normal saline, we see this the normal saline, and if any collection or any mass will present in the endometrium, and by ultrasound this the polyp دائما تكون white collecting material unless she had cystic changes may present as a fluid inside it, like this picture. This folly catheter or intrauterine catheter, and push fluid, and this the mass present in the inside the uterus. Endometrium polyp should be removed, either hysteroscope or under GA by dilatation and curettage. Another submucosal leiomyoma also present. This picture is a whitish because of fibrous tissue and present of enlargement and hyperplasia of the uterus. Another abnormality is endometrium. This mass diffuse process of early cases and appear as a polypoidal mass, all of it related together. Hysteroscope is performed in outpatient setting under local anesthesia where possible GA. Anesthetic is required in patients with cervical stenosis or where hysteroscopy is poorly tolerated and difficult to insertion. Hysteroscope, what is the benefit? Visualization has several advantages. Immediate office evaluation, visualization of the endometrium and endocervical, ability to detect minute focal endometrium pathology, and to perform direct endometrium biopsy. About the management of the postmenopausal bleeding in general, endometrial hyperplasia influenced by the age, history, fertility, desire. Number one, progesterone therapy. Patient not candidate for surgery, desire hair fertility, and for simple hyperplasia, not atypia. This present by histopathology, and lasted for 3 to 6 months. Number two, surgical treatment indicated for the hyperplasia with atypia, total hysterectomy, abdominal adhesion, vaginal prolapse, dilatation and curettage alone may on occasion be therapeutic and curative with on further bleeding and normal histological on follow-up biopsy. Endometrial cancer management is primarily surgical with other modality and adjuvant depending on the tumor grade and the stage of diagnosis. Thank you for listening.